हेलो। 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 हेलो।
सर सर गुड इवनिंग।
गुड इवनिंग, क्या हाल है?
बस बढ़िया सर।
आनंद से बात, इनसे बात हो गई थी अपने सुरेंद्र साहब से?
जी जी जी, बात हो गई थी, दोपहर में बात हो गई थी।
अच्छा अच्छा। सुरेंद्र, आर यू देयर?
वो सर
हेलो।
अभी ज्वाइन नहीं किए हैं सर।
नहीं ज्वाइन किया तो ठीक है। वेलकम।
थैंक यू सर।
वेलकम वेलकम। क्या हाल चाल?
ठीक है सर, मैं ये स्क्रीन शेयर का ये एक बार देख रहा हूँ। स्क्रीन स्क्रीन
यहाँ शेयर कीजिए, यहाँ से।
शेयर स्क्रीन, हाँ आ गया।
अभी टाइम है, वी हैव 5 मिनट्स टू गो। आ गए डॉक्टर? डॉक्टर साहब वहां से, गुरुग्राम से?
हाँ, आने वाले हैं।
अभी चंद्रा साहब?
अभी उनकी टीम आई है, अभी पेशेंट को ले लिया है।
ले लिया गया है।
हम्म। सर एक बार बताएंगे कि दिख रहा है क्या कुछ सर?
दिख रहा है, दिख रहा है, बढ़िया दिख रहा है, सुंदर दिख
स्लाइड्स
रहा है।
स्लाइड्स दिख रहा है क्या सर?
बस स्लाइस दिख रहा है।
अच्छा, ठीक है।
इसको आप फुल स्क्रीन कर लीजिएगा।
हाँ
आनंद जी, डॉक्टर तिवारी को बुलाइएगा 1 मिनट के लिए। प्रोफेसर कमलेश तिवारी साहब को बुलाइए। आनंद जी।
सर अभी मुजफ्फरपुर में है नहीं सर, वो कांचीरंगा के आसाम।
अच्छा, है नहीं अभी तक लौट के?
नहीं
अच्छा
नहीं
अच्छा।
आया है। हाँ जी।
चलिए ठीक है, तब कोई बात नहीं।
ठीक ठीक।
आनंद, सबको इंटीमेशन दिया है सिनॉप्सिस देने के लिए?
यस सर।
सबको इंडिविजुअल लेटर दीजिए भाई, कॉपी टू मी, कि अपने अपने दिए गए टॉक के आधार पर एक सिनॉप्सिस बना। ठीक है?
ओके सर, ओके सर।
हाँ, बहुत जरूरी है ये काम।
नहीं जी, ठीक ठीक सर।
लास्ट में नहीं हो पाएगा ना, लास्ट में गड़बड़ हो जाएगा।
जी जी जी।
हम लोग ये प्लान कर रहे हैं सुबह,
यस सर।
जितने लोगों ने अभी तक प्रोग्राम किया है, सबों का एक राइटअप आए, सारांश आए,
यस सर।
जिसको हम लोग एक कैंपेनियम बना के कमिंग एपीआई में रिलीज करेंगे कॉन्फ्रेंस के समय,
हाँ, अच्छा आइडिया है सर।
है ना? तो तो uh, Anand, is it the right time to start?
यस सर।
Yeah, so this is a very proud moment for me to introduce Dr. Suvain, who is right into my heart.
Thank you,
And
sir.
he's a guy who is son of a soil, did his graduation from all prestigious All India Institute of Medical Sciences, New Delhi. And I was just trying to locate his uh, CV. So, yeah. So, Suvain has remained in USA for quite some time. And I don't know what made him to come to our country. Certainly the smell of, जो कहते हैं ना, मिट्टी की सुगंध. And I tell you that he has remained and he has had laurels in America, a lot of achievements, and he has worked in Mount Sinai and so on and so forth. And I hope that he's going to make a big dent in our state at Medanta. And the most impressive thing about this young fellow, I like him. I always call him young because he looks very dynamic all the time. And uh, is that he's doing human services in Gaya, both Gaya, and where he is imparting his services almost free of cost. जो दे उसका भी भला, जो ना दे उसका भी भला. That is what his principle is. And we decided, all jointly we decided that we are going to have a very interesting topic, and that is chest pain clinic. Because, often we are in trouble because of chest pain. And so before he starts, I must thank Professor Kamlesh Tiwari, sir, for his vision of starting this project, of educating PG students, the junior doctors, and the peripheral doctors. He always emphasizes that peripheral doctors are deprived. They are not having enough skill and know-how. So I must thank him, and I must thank all the stalwarts of API, President, our secretary, our dean-elect. So with your formal permission, I would now invite Swain to take us to the journey of chest pain clinic. Thank you.
Thank you, sir. Thank you for your kind words. It's just your blessings that, the destiny all coming together, that I have been working at this great institute here. And it's with God's will that I have gotten the opportunity to serve in both sides, at Medanta also, and also in the rural side, so that both ends come and meet together. And I would just share the screen here, and just let me know if everybody is able to see this screen.
Yeah, we are.
Yes. So, first of all, the topic, I think it is about chest pain, but the title actually, it was suggested by Ajay sir, and it's a very interesting title. And the reason being is it could be chest pain evaluation, but chest pain clinic, the reason is because in the US, more we become specialized and specialized, and more and more patients who come with these symptoms. There have been actual clinics which are named chest pain clinic, which is specialized in just chest pain symptoms, and they will come, and it's so streamlined and so specialized. And it's effective in ruling out in important things. So I think this would be a great stuff in future. With that, I would like to start just a disclaimer that this is not going to be full comprehensive chest pain, because as we go deeper and deeper in medicine, there is no end or there is no limit to it. So I would keep it basics. And I don't think I am going to share anything which is new to all of you. Everybody has done med school residency. But I hope there is something new, or maybe the approach you take home, and it would be very fruitful for you in future. And actually, by giving this talk, it becomes fruitful for me as well. More we teach, more we learn, and I encourage each one of you to do the same thing. So first we'll talk about the learning objectives. So what we are gonna learn is differential diagnosis of chest pain, uh, initial approach. We will learn about identifying emergencies, and we will learn about basic investigations and basic therapies. And remember, this is all about evaluating chest pain in a clinic setting. That clinic can be in a hospital. It may not be in the hospital. It could be in rural area or which is not attached to the hospital. So just be mindful that this is not a complete, but this is a good. It can be a good triage. Triage, that means that we have to rule out, rule in, and treat or diagnose patients appropriately. At least send them in the right direction. Sorry, my slide is going backwards. Okay. So, when we talk about etiologies, as a cardiologist, we see it as cardiogenic and non-cardiogenic. I think as cardiologists, at least me, I can say we become we have glasses that we need to know the heart, and then rest is non-cardiogenic. But for all of you, and including myself, I would encourage to look at this in a broader sense, um, that it can be everything related in the chest area. So we have to think about it can be upper body, it can be lungs, it can be chest, it can be skin, it can be GI related, stomach, gallbladder, pancreas, everything which is in the chest or close to the chest. And sometimes whole body, whole body is aching and patient will come and say they have chest pain, and sometimes it can be brain related as well. So I would encourage to have a broader look when the patients walk in. So first thing first, we need to identify the emergencies first, because if we do not recognize that in time, then it would be too late, and that won't be right. So first thing, we need to ask whether the patients are having ongoing chest pain. This is very important. Are you having chest pain right now? Sometimes they will say, not right now, but 1 hour before, 2 hours before. At least if it's in the same day, I would still consider that this is ongoing chest pain. The reason being because this is my experience here after coming back from the US, that many patients in India, they have very good pain tolerance. I have seen patients with aortic dissection who unfortunately passed away a few hours later. And when I actually saw the patient, there is no way I could see just based on the symptoms that he was having aortic dissection. If you ask him about the pain, yeah, it was there. So things like that we have to keep in mind. Not everything is written in the books. So emergencies, we need to act fast. So what are the main emergencies which can cause problems? Again, anatomically, it's easier to divide anatomically: heart, lungs, or esophagus. So what can happen in the heart? ACS, as we all know, acute coronary syndrome. It can be, you can call it myocardial infarction. That means the coronary arteries are acutely involved. Aortic dissection, I just mentioned, the tear in the aorta. Myocarditis and pericarditis can be acute and can be deadly as well. And of course, tamponade, this large amount of pericardial effusion compressing on the heart and then decreasing the cardiac output. And then if you talk about in the lungs, pneumothorax, pulmonary embolism, and in the esophagus, esophageal perforation. There are multiple ways to remember this. One common one, they call it 421. There are four major emergencies in the heart, because heart has four chambers. Lungs, there are two lungs in the body, so two for lungs, and there is one esophagus, so one for esophagus. You don't have to remember in this way, whichever way you are comfortable, but I always see anatomically heart, lungs, or esophagus. So how do we identify those emergencies? First thing first, as in medical college, we learn about evaluating patients clinically. We check the vitals first. So again, heart rate, blood pressure, and so on. So if the vitals are unstable, we should start thinking about, or actually, depending on how bad it is, we should start arranging for the patients to go to a hospital in a tertiary center, because anything can go wrong any minute. So if you hold on to those patients in the clinic, it can be detrimental, because each minute counts. As you know, in coronary syndromes and in aortic dissection, anything can go wrong anytime, and that won't be very good. Stable patients, if the vitals are stable, you can definitely initiate basic workup and then move on from there. So again, first thing, vitals first. You identify, first thing you need to know, chest pain, are you having today? Yes, now. If they're having it now, just be mindful that this can be an emergency, this can go wrong. Just start thinking fast. Unstable, definitely go now. Not unstable, then you can initiate basic workup. So, what are common and essential basic workup? Most of the clinics, I'm not sure if you will have ECG. If you have, then definitely do the ECG. Some clinics also have a troponin kit, which is cardiac biomarkers. It's very common these days. If you don't, then I would recommend having it there in the clinic. Some clinics which are associated with a mid-size or small hospital, they also have CT scan or chest X-ray. So if you have those, you can initiate these workup only if the patients are stable. So what are the most common emergencies we deal with? And this is, I'm talking about, I'm not going to talk about the full management, but as you see in this ECG, there is ST elevation, if you all can see in anterior leads. I'm not gonna, if you're familiar with ECG, is fine. If you're not, this can become a very big lecture. But as you can see in V1, V2, V3, there's a ST elevation, and you can see reciprocal lead. These are anterior leads, so inferior, which is 2, 3, and AVF, there is ST depression. Very concerning of acute coronary syndrome, and actually ST elevation, we call it ST elevation myocardial infarction. This is an emergency for sure. So you know that maybe the patient was stable, but now this is an emergency and you need to send them to the hospital. So if your clinic does have basic initial medications, that can be very helpful, which is aspirin, ecoaspirin we call it here. 300 milligram, you have to load the patient. Oxygen, if you have oxygen, you can give the patient oxygen and then transfer the patient. Sublingual nitroglycerin tablets are also given, but you need to be mindful in this. If there is a right ventricle is involved, if it's an inferior ST elevation, so you need to know different types of ST elevation also. That can, I think we can cover in a different lecture, but that is extremely important. If you give nitroglycerin to those patients where right ventricle is involved, their blood pressure can tank immediately in front of you, and then it would be too late. So if you are not sure, then do not give nitroglycerin. Just transfer the patient ecoaspirin, oxygen, and transfer the patient. And always follow the ACLS protocol if the patient become unstable. You know, we learned about airway breathing, so on. The ACS protocol you have to follow. If the patient become acutely ill in front of you, if heart stops. But again, if the patients are unstable but heart is beating, then these measures you can do. So if it's not an emergency, and the rest of the other emergencies we talk about, there is no such initial treatment you can give, you should give in the clinic. Just oxygen, that's a maximum you can do if the blood pressure is low, and if you have the facility to put an IV and do IV fluids, you can do those. But again, be mindful, if the patient is in heart failure, then if you give too much fluid, the patient will crash. So again, if you're not sure, just arrange for the transfer. Then moving on, if you have determined it's not an emergency, and the pain was also chronic, it's happening for months and months or maybe years, and the patient is stable, then you can think about, just relax and think about the differential, wide range of differential. If you can see above section, that's life-threatening causes. We just talked about pneumothorax, we talked about aortic dissection, we talked about myocardial infarction, which is heart attack, esophageal rupture, pulmonary embolism. So the patient was stable. Is it possible that stable patient can have these? Yes, it is definitely possible. I've seen many times. I'm sure you all have also seen. But if the patient is stable and then chronic symptoms, you can think about these other differential as well. So again, it's easier If you have photographic memory, if you Google or go to any book for chest pain, you will see a long list of differential. For me, unfortunately, it was not possible to remember each one of them like in my brain immediately. So what I do is divide this chest, like I said before, anatomically, what's inside the chest and around the chest. So again, if you see coming from the anterior, so if you see skin is there, then ribs are there, muscles are there, nerves are there. If you go inside, heart is there. We talked about in heart aortic dissection, heart attacks, that is acute coronary syndrome, and pericarditis can be is another cause of chest pain. Esophageal spasm can be there. If you can see going inside further, you will meet esophagus and various problems in esophagus again. And then if you go to GI causes, so stomach, although it is in the abdominal area, the pain can radiate, the pain can be elsewhere also in the surrounding area, gallbladder related. Many times pancreatitis, they will have abdominal pain, and then they will also have a vague chest pain also. And another thing is sickle cell crisis. So the different differentials in mind, and the reason to know the differential, I would say, whenever you do history taking and physical examination, always need to know why you're listening, what you're listening to. If you're checking pulse in both hands, what are you looking for? If you're checking blood pressure in both hands, you should be knowing, okay, if the blood pressure is different in both arms, I should be concerned about aortic dissection. If you are listening to heart, auscultating the heart, and if you hear a loud murmur, and if you can differentiate different kinds of murmur, it's great. But if you cannot, then just know that there is a loud murmur. That's enough to know that the heart is involved, some valve is involved, and it is possible to that due to myocardial infarction, some damage has happened to papillary muscle, and mitral valve is the chordae has ruptured. So these kind of things you should know when you start doing this examination, when you ask these questions in the history, because now you know the patient is stable, he has enough time, you can ask these questions. So always keep in mind about these differentials. So let's talk about the history a little bit. There's hundreds of questions you can ask, but not all questions can be, or answers can be relevant to what you're looking for. So again and again, I'm emphasizing, whenever you are asking in the history, you should know what you're looking for, what answer you're looking for. You should be focused. And you should know what these questions mean and how much sensitive these questions are, because there are some symptoms, characteristics are important, statistically shown in research, some are not. So these the one I have listed, they have been shown to have statistically significant likelihood ratio of suggesting one kind of pathology to other, like say chest pain which gets worse with exertion. It can be related to coronary artery disease. Same thing with relieved with rest or nitroglycerin. If it's radiating to neck, jaw, or arm, any arm, left or right, it can be related to coronary artery disease. Same thing with if it's associated with diaphoresis, more in with vomiting, it can be related to acute coronary syndrome specifically. And this has been shown in research about these questions. So I personally ask very specific questions. If it's not in this, if it's not proven in research statistically, I don't even ask these questions, because then if you start taking multiple characteristics, it can be really, really long and it won't be fruitful. If it's sharp, it's less likely coronary artery disease. If it's pleuritic, that means if the pain worsens when you take a deep breath, it can be related to pleura, it can be related to the lungs, and it can also be related to pericardium. If it's positional, so if the pain gets better when person is leaning forward, then it can be related to pericardium, pericarditis. Again, another one which is more like examination thing, but also patient would say that when they press, it hurts more. Tenderness. If the patient saying it's like tearing my heart, it's tearing my back, it's like knife stabbing, it's more shown to be more inclined to aortic dissection. So all these characteristics you have all learned, we all learned in med school. However, there are many patients, they will fall out of this category. So history is extremely important, but in this era of technology, we should definitely rely on these things. But this will help you. But nowadays, I have seen, especially in this region in Bihar, that the characteristics have fallen out of place, which is very surprising. Many patients, they won't even have anything. They will just say, I have jaw pain. There is no chest pain, pressure, or heaviness at all. I have this jaw pain. And they will, if you check their troponin and it's a positive, and then you take him to angiogram and it's acute occlusion of one of the arteries, which is very surprising. That means, what does tell us? Um, I don't think it suggests that we should do all kinds of tests in all the patients of any symptoms, but we should definitely keep this in mind that many times these patients will complain of symptoms which doesn't fall in any category, but still can be related to all these serious problems. And if all the other investigations are not positive and we are not, you have not found an etiology, then think about these atypical ones definitely, especially in women, which has been actually statistically proven that they will have atypical symptoms to begin with. Okay. Targeted exam or focused exam. As we talked about, you always do vitals first, which you did when you saw somebody who is having ongoing chest pain before you start going with the history and stuff in those unstable, ill-looking patients, or you start with vitals. But if they're stable, then you can take the history, take your time, and then you check the vitals again. Blood pressure and pulse in both arms, extremely important. Focused cardio neuro exam, as I talked about, auscultation, you should be knowing what you're looking for. Are you looking for pericardial rub? If you can. Are you looking for heart failure signs? So are you looking for raised JVP? Are you looking for abdominal distension? Are you looking for a pattern of breathing? You should definitely palpate the chest to see whether this pain is reproducible. That means they will have tenderness. So these things you should keep in mind. Look at the fingers, look at the skin, look at the legs for sure. Sometimes heart failure patients, especially with certain type of heart failure patient I want to mention because they're missed in outpatient settings. These are not a typical congested heart failure patients. These are, we call it cold and dry. So their lungs are not filled with water. In common word, lungs are not congested, so they don't have pulmonary edema. But their cardiac output is so low, their fingers, their extremities will be cold to touch. So just keep these things in mind. Always make sure you look at the hands and actually touch the hands and legs, because it can be an emergency which is sitting, brewing, chupa rustam, especially that kind of heart failure who are in cardiogenic shock. When I say shock, when you hear shock in ICU, you always think about low blood pressure, because these certain specific type of subset of heart failure patient, they will not have low blood pressure, but they can crash anytime. So always keep that in mind. Sometimes, as you all know, you have encountered many times that we know about medicine, just it's a tip of the iceberg. What there's a lot of things beneath. So just keep everything in differential, targeted exam, targeted history, what you're looking for, you should know. So let's talk about basic tests. I think most of the clinics I have seen here, they have ECG. One habit I would like to recommend that always compare with the old EKG, old ECG, always. So some of you may be an expert in looking at how ST elevation looks like in STEMI, acute coronary syndrome. Some of you may be very good in looking at ST depression T-wave changes, sometimes T-wave inversions happen, sometimes new left bundle branch block happens. But if you don't know any of that, if you are like, no, I don't know ECG, and you have an old ECG, you can just compare. It's like a puzzle. You know, in the newspaper, when you used to two pictures, you have to find the differences. If you see that there are changes, patients are complaining of chest pain, then you need to think that, oh, this can be ischemic, this can be ischemia. Axis change of axis. That you don't even have to calculate the axis if you have old ECGs. Just look at the ECG every lead and see what are the differences, and then if there are differences, just be alarmed and do the next steps. So there are some examples of the ECG I will show you here. It's a 12 lead ECG, and as you can see, there is ST elevation in lead 2, 3, and AVF. If everyone can see, and there are some reciprocal changes in 1 and AVL. So again, to recapitulate, 1 and AVL is on the left side, left lateral, because L is left. If you are familiar with the ECG, you will know. 2, 3 AVF is pointed downwards, so those are inferior leads, and V1 to V3, V4, these are all anterior leads, and again V5, V6 becomes lateral. So as you can see, there is a ST elevation in 2, 3 AVF. This we call in our department. It's a very common presentation of acute coronary syndrome, STEMI, that requires immediate attention, immediate treatment, and there is time is money in this. So always be mindful. Everybody should know, if you have ECG machine in your clinic, most of the machine, if I'm not wrong, they have AI built in these machines for a long time, and they will tell you it's an STEMI. However, I have seen many machines which doesn't, you have to identify on your own. So everybody should be able to look at the ECG and see, maybe not the leads, maybe not the location, but you should know, oh, there is some ST elevation I see, I think this needs immediate attention. At least somebody, if you don't know how to, then somebody should look at it, refer this patient to somewhere in time. This ECG doesn't look that dramatic, but if you see, there are some STT changes. We called it STT changes. That's ST and T. Any of these are involved, it can show ischemia. So if you see here, lead 1, lead 2, AVL, they have T wave inversion. And if you see on the other side, V4, V5, and V6 also have T wave inversion. And also some leads have some ST depression as well. This can be also a sign of ischemia. So just be alarmed that any STT changes that you see, and if you're not sure, always ask for help. This is the basic rule in medicine. I would recommend everyone to follow. If you're not sure, ask for help. Ask for help. Another dramatic ECG here. Like I was saying, there is a ST elevation. And how do we know ST elevation? You all know P, Q, R, S, and T. So S is the end of QRS, okay, and then it is elevated. Some people compare it to the baseline PR interval. Some people recommend comparing it to TP interval. I would recommend, many times the baseline will go up and down, but always compare it to both, I would say. In this one, as you can see, there is clear ST elevation in inferior leads with 2, 3, and AVF. That is sure. Okay, this is in myocardial infarction. But also, when you learn to read ECG, you should know that we should start with basics, P, Q, R, S. So look at the P waves. If you look at the P waves, there are a lot of different P waves, and they're not following QRS all the time. There's some random P waves appearing. And if you know how to diagnose complete heart block, this is complete heart block. Maybe because this right coronary artery, which also has a branch which supply to the AV node, is blocked. That's why he's having no blood supply in AV node and complete heart block. This is a very common presentation, and this is an emergency. You need to send the patient to the hospital immediately. So learn to recognize these ECGs, practice and practice and practice. Okay, cardiac biomarkers. Once we are done with ECG basic test, cardiac biomarkers, as I said, nowadays we have kits available which can give you results in minutes and doesn't take the blood draw and send it to the lab and come back. That you can do also, but if somebody is having acute pain in the clinic or heaviness in the clinic, then that can be challenging. So this kit one is very helpful. And as you can see in this graph, there are different timing of different cardiac biomarkers. I will not go in a lot of detail. As you can see, the first one to rise is myoglobin. We don't test, but troponin is early and it lasts very long. So if somebody, just an example, if somebody had a heart attack 2 days ago and gets an angioplasty, he goes home and for some reason he goes to hospital and they check the troponin, it will be positive. When in doubt, first thing you should do in ECG, biomarkers, always, or any any lab values, you look for the old one. What does the old one say? If you are looking at an X-ray, oh, what does the old one say? Always try to compare. That will solve many questions. Another cardiac biomarker is BNP, and some labs will have NT-proBNP. I think either one is fine. This signifies heart failure. This is also elevated in other stuff as well. But you should know, if you have some heart patient, you can order these as a cardiac biomarker, which may have significance later. That management is in the hospital, not in the clinic. Again, chest X-ray is another basic one you can order if you have. And what can X-ray show? Pneumothorax, as you can see on the left side, there is no lung markings here, and you can see the left side of the lung has collapsed, and there is some mediastinal shift to the right as well. So very extremely important. If you have in your clinic, attached to your clinic, you can get a quick chest X-ray. But again, same thing. Patient is unstable. Don't think. Don't waste time. Send to the hospital. CT, if you work, your clinic is in a mid-size or some hospital which has this capability, CT chest angiogram. Angio is mean blood vessel, and that requires dye. So that means require more planning. You need to know what the kidney function is. However, when you are concerned about emergencies, you just do the CT scan if you have. Again, I always recommend doing these advanced tests in a hospital setting, not in the clinical setting. However, if this is a chronic pain, you can think about these things. Sometimes chronic pulmonary embolism is not an acute emergency. So as you can see, the top A and D, that's the aortic dissection, that's the aorta, and then there is the marking dissection. As you can see, there is a tear in the aorta. If you don't know the CT, it's fine. And the lower left side, there's a picture, that's a white, I cannot have an arrow here, but that's a pulmonary artery, and there is a big clot there, that's a pulmonary embolism. So again, CT can be very helpful, especially in ruling out emergencies. However, if you're not sure, send to the hospital to get this done. I would like to talk about this coronary angiogram. I cannot say this is new. I would say relatively new kid in the block and very, very helpful. We should all at least know about this test, which can rule out coronary artery disease. In specific conditions, there are some limitations, but the advantage of this test that it has almost pretty good negative predictive value. That means if it's saying you don't have coronary artery disease, you don't have coronary artery disease. Gold standard is obviously cardiac catheterization and coronary angiogram, but not everybody can go invasive testing or should go invasive testing because it has some small risks associated with it. We are inside the heart, shooting dye, anything can go wrong, although very, very low. Then this comes in and plays a very important role, coronary CT angiogram. There are some limitations. Again, I said, if it's saying you don't have disease, it's normal. Then where the problem comes? Sometimes, as you know, in coronary arteries, there's a lot of calcification, calcium deposits. This is when it gets problematic. Many centers, especially in the US, they don't even finish the angiogram. That means they do not give the dye. And how this CT is different from regular chest CT. Heart is moving. So when you get the CT, it gets blurred. If you have looked at the regular chest CT, it will be blurred. The heart will be blurred. It won't see even if you have the dye. So what this coronary CT does, it recognizes the ECG and it's gated. We call it gated. So it's every beat, there is specific time, it gets multiple slices, joins them together and forms an image for you and software based. And since depending on how fast or what slice CT you have, I think we need at least 64 nowadays in many cities. 128 slices available. That can be very good to run this coronary CT. However, the technician or the radiologist have to know the protocol, how to gate this and how much contrast to use. Before they do this CT, they always run as a, you may have heard, coronary calcium score. Has become very popular in the United States. Maybe in India also, I haven't seen that very much. Coronary calcium score, just plain cardiac CT with calcium score. That is not an angiogram. That's why I want to specify when you write these tests. Actually, it has happened to me. I had written this test once and I was in some periphery, coronary CT angiogram. The patient comes to Patna and gets a cardiac catheterization. Patient is happy because he doesn't have any disease. But however, it is wrong. I wanted to order something else and something else happened. So very specific, you should know it. Coronary CT angiogram. It's a coronary CT, it's a gated CT, and it has an angiogram component. That means the dye will be injected. So when you counsel the patient, you need to tell them the dye. If they ask you, oh, is there any risk? Yes, there is a risk. Iodine dye can be problematic for the kidneys. So you should all know before you order this test, this is not a just a plain X-ray. This has some risk, lower than coronary angiography through cardiac catheterization, but it does have some risk. Again, limitations, if there's a lot of calcium, as you can see, this white portion in these images, and again, there's some images which are reconstructed by software. But these white portion, that is the dye. And if you see a small, that's an artery there on the A, B, and C. And then there is a 3D compilation by the software on the picture D. So the dye is also white. Unfortunately, calcium also appears white. And when there's in this image, it's fine. But when there's a lot of calcification, actual quantification is very, very misleading. Very, very misleading. So let's say, for example, and many centers, they do not even complete the angiogram if they see a lot of calcium. They cancel the test. But many centers, they will finish the test, they will say it's 50, 60%. Then you definitely need expert consultation and patient may need further evaluation. That doesn't stop there. So, I'm again emphasizing, if the test is 100% normal, no calcium, there's no stenosis, maybe less than 10%, then you're fine. You can tell the patient confidently that you do not have disease, because this test has a very, very high negative predictive value. But if there is some stenosis, you should not be 100% sure that you have 50%, 60%, because the assessment can be wrong, especially when there is calcium. Okay, moving on. Stress test, extremely important, extremely common to do. TMT, as people call it here, treadmill test. In other parts, exercise treadmill test, ETT. And that has, it's linked with the ECG. Patients run on a treadmill. There are a lot of calculations and interpretations in that one. But unfortunately, if you're looking for coronary artery disease, this test has very poor sensitivity, almost 55%. So it's like slightly better than coin flip. So if you really want to know, if the patient asks you, are you sure my TMT is normal, I don't have disease? No, you cannot be sure. Only because 55% is not good. So what do? If you do a stress test with added imaging, like echocardiogram, maybe nuclear imaging, then it improves the sensitivity, takes it to 85 to 90%, which is pretty good. So let's talk about the stress test in little detail, because this is the test. If you have a primary care clinic, or even in the hospital setting, many times you will need. So stress test has two components: stress and test. What kind of stressors you have? Exercise, obviously very common. And then there are some vasodilators, and then there are some inotropes or chronotropes. So exercise, you all know what kind of exercise we have: treadmill, we have bike, we have supine bike, many kinds. The most popular is the treadmill. There are different protocols. You can go in detail if you have that in your clinic. Vasodilators, you have adenosine, which was used long time back. Here, I see Percentine. These are some vasodilators which dilate the coronary arteries. And then new ones is Regadenoson or Lexiscan is popularly called. These are all similar things. They all do dilate the coronary artery. And chronotrope, dobutamine, you may have seen already when you order. So these are stressors. Stress test part, how do you test it? ECG, as I said, ECG, just plain ECG with exercise has very poor sensitivity. And once you are using vasodilators and chronotropes, inotropes, dobutamine, then you will add some kind of imaging, either nuclear or echocardiogram. MRI also you can do, but it's less popular, more expensive. But when you add this imaging along with the ECG, because ECG patients are hooked up to anyways, either you're doing vasodilator or dobutamine, it improves your sensitivity and specificity as well. One problem with these chronotropes, inotropes is patients do not like it. It's dobutamine increases the heart rate very fast. They feel like they're going to die. And risk of arrhythmias are very, very high in these dobutamine stress tests. So, know about the stress test. What are the drawbacks? When you talk to patients, counsel them properly when you do. But as I said, you should know the sensitivity of plain exercise treadmill test. If you are just looking for coronary artery disease, it is not going to be very good test. Again, a caveat to this whole thing: when you move on to stress test, you may have read something called pre-test probability for coronary artery disease. So, and that you can learn, you can in some other lecture, how if we have a lecture of coronary artery disease, how we just focus on diagnosing coronary artery disease. Pre-test probability. If your pre-test probability is very, very low, just a stress test, it will not take it too high. If your pre-test probability is intermediate, stress test helps you in taking that probability either higher or lower. If it's high, then the patient is going for an angiogram, which is an invasive test. So these are some ways to triage this, but know this. The basic point was to know the stress. What is stress? What is stress? There are different kinds of stress. There are different kinds of tests you need to do and know the sensitivity. When you answer these patients, patients come, oh, okay, stress test is normal, that means I do not have disease. I say, most likely you do not have disease. I'm diplomatic and sometimes tough for the patients to understand, but this is the brutal test. Many times stress tests are negative, patient gets heart attack next month, and he will remember you forever. That okay, I asked, he said everything is normal, I got heart attack. Many patients who came to me in the cath lab and I did their angioplasties, they always remember their doctor that, oh, he ordered a stress test, it was normal, I don't know how it happened. So again, be very mindful when you talk to these patients. Okay, again, just to summarize this whole thing, keep differential diagnosis in mind, all the difficult, all the life-threatening ones. Again, acute coronary syndrome or heart attacks in the heart, myocarditis, pericarditis. Some people may think myocarditis, how can it be emergency? It can be really bad emergency, because when the heart is inflamed, the cardiac output, the heart function can go really, really low. If pericarditis is involved, it can have pericardial effusion as well. Both together, not a good combination. When the heart function is low, the cardiac output is very low, patient goes in shock, and sometimes it is not responsive to just those pressors, which are like noradrenaline, adrenaline, so, and may need mechanical support like Impella, which is left. So again, advanced therapies. So it can be an emergency. Pulmonary embolism in the lungs, as I said, aortic dissection. These are the emergencies, but there are many differential diagnoses I talked about before. Just remember anatomically what goes from the top to bottom. Heart is the main thing. Okay, I am a cardiologist, so I'll think about the heart first. But for you, you should think about heart, lungs, GI, everything. But heart and heart-related structures first, because most of the emergencies are there. Lungs, pulmonary embolism comes higher because those are the emergencies. Other stuff, skin, yeah, it can come later. You can think about that later. Sensitive skin, costochondritis, they're easier. Not easier to handle because these patients will be very unsatisfied because all the tests will be done and they would know, okay, why am I having chest pain? So, triage appropriately, do the appropriate basic tests, not going in the detail. If you have ECG, do the ECG, make sure it's normal. If your ECG inbuilt machine has AI technology, fine. If not, then learn. If you have the ECG machine, learn to look at the STT changes, either going up, down, learn to see whether T wave is upright or going downwards. Learn to locate the P waves as well, whether it's a complete heart block or not. Basically ischemic changes. And if you can have a high sensitivity troponin kit or troponin kit, that's fine. Risk assessment you should do based on symptoms, exam, and other stuff, and then decide what to do. Either send to the hospital for emergency care, or the patient is stable. You can think about doing these stress tests we talked about, nuclear stress test or exercise echocardiogram. If you think patient cannot exercise, obviously you can do pharmacological using vasodilators. But again, very, very important test we talked about in great detail, coronary CT angiogram. Be mindful in how you write the coronary CT angiogram. Because if you just write coronary CT, some people can get confused. They will not do the angiogram portion depending on the center. Here, they are all, when we write coronary CT, here at our institute, they would understand it's a coronary CT angiogram. Okay, and very good test for ruling out. I do it in young patients, which I think it should be ruled out, and I should be confident in saying you do not have disease. So again, this was a basic summary. Keep these in mind, and again, be very mindful. Many times things are missed. So this was a quote I had seen somewhere. The chest pain whispers before it screams. Sometimes the patient would be stable in your clinic and the next moment you don't know. So you just train your ears and eyes to hear it. When it's whispering, you softly do the right things in time so that patients are treated appropriately and life is saved, basically. Thank you, everyone. And I would like to hear if there are any questions.
So thank you, Suven. Great, great summary of chest pain clinic and how to triage and how to manage and what are the requirements, how much you should have in your clinic. That was wonderful. Any question from anybody? I saw there was the question in the chat box. EECP, enhanced external counterpulsation in angina. I do not know. This is not evidence-based so far. People are using across the world, across the country. There are many centers now, but I do not have the correct exact answer. Suven, can you highlight this?
There are some papers which say there is data, but honestly speaking, I have not seen in any of the centers I have worked in, and I have worked in small hospital there as well and a big center. I'm sure Harvard will have it for research purposes, but not many universities have it because the data is not very strong. So yeah, the symptomatic management, yes, it's there in the books as well, but I have actually not seen it actually being applied and patient being helped.
Aspirin can be given on the basis of clinical suspicion. I think yes. So they will agree that this.
Yes, aspirin, like I said, you can give on clinical suspicion. I would avoid the.
Yeah. Go ahead.
If you do not have ECG, if you're concerned about heart attack, unless you do the ECG, because those patients, they're having chest pain right now, maybe 1 in 1,000. But if that happens in front of you in your clinic, you give the nitroglycerin. If they crash because they were having right ventricular infarct, then that can be detrimental before they can reach the hospital. So aspirin you can give, maybe atorvastatin also you can give. But I would avoid nitroglycerin if the patient is having really acute chest pain unless you do the ECG.
So quite right. We have to be very careful about giving nitroglycerin. Rightly, Dr. Swain has said that, sometime if you have RV infarct or inferior infarct, then giving nitroglycerin can be detrimental. Patient can crash and go into hypotension. So you have to be careful. There's another question. When intracranial hemorrhage occurs alongside MI, then how to manage? This is a catch-20 point. I don't know. Dr. Swain, can you comment on this point?
Yes, it's a very, very good question. And this is a good question not only from you, but the whole medical community. And it can be extremely challenging. And unfortunately, when there is an intracranial hemorrhage, we cannot do cardiac catheterization for above mentioned reason, because we do, there is no point doing cardiac catheterization, because once you do the angioplasty, you need to use some antiplatelets, some anticoagulation, which you cannot. So unfortunately, these patients, they have a very, very, very poor prognosis. And yeah, there is no right or wrong answer. Definitely, nobody will do an angiogram on these patients with intracranial hemorrhage. That's a contraindication.
Calcium score, how favorable is calcium scoring compared to other diagnostic? As Sven has already highlighted the point, that calcium scoring is meant, do an epidemiological study to stratify the risk rather than to make a diagnosis. Because high calcium, this doesn't make any diagnosis. You can only say that higher the calcium score is, the more is the chances of problems. So this is a kind of initial entry point. But calcium scoring can be done easily. So this is a very good sort of community workup. When you're trying to, somebody comes with chest pain, and if you have the facility of calcium scoring, so do a calcium score, and then you can decide, like what to do. So this is one.
Most commonly, I personally, calcium scoring sometimes puts you in dilemma. So
Yeah.
usually this, in the US, this test is ordered by primary care physicians, internal medicine. Very rarely some cardiologists will order calcium score, because the patients read on this, on Dr. Google tells them, and they will come and tell you, I need to have a calcium score. It's a good thing for risk stratification. Let's say there is some calcium score, then maybe you can start statin therapy. They don't want to take statin therapy just based on their LDL, so that it can help. But the problem becomes when the calcium score is high and the patient doesn't have any symptoms. So calcium score is very high, let's say 400, and they don't have symptoms. Then it is a very difficult situation whether do an angiogram or do a stress test. So let's say you do an angiogram and there is some stenosis. There is very, very weak data to support asymptomatic angioplasties. So then it becomes a dilemma for the cardiologist who is doing the angiogram. So again, so just use it wisely. Think about all these repercussions of having, if it's a normal result, no problem. But if it comes abnormal, then what to do? Always when you do order these tests, I would recommend, think about what are the repercussions when these tests come back positive or negative, what we are going to do.
So another question is there, when is the PTCA preferred and when is CABG preferred? I mean, this is a very common situation. I mean, guidelines, what do the guidelines say? Suvin can tell.
So again, this is a little very specific question, more appropriate in the cath lab. So, okay, first, if you're asking this question, that means an angiogram is done and there is some blockage or stenosis in coronary artery. So we know that there is coronary artery disease. In general, when there is a multi-vessel, so 3-vessel disease is involved, the left anterior descending is involved or left main is involved, we should start talking about bypass surgery. However, this question is not that simple. There are a lot of scoring systems in the place, comorbidities, age factor, other risk factors, COPD, patient's preference. There are so many things which we take into account um, to answer this question. Many times the patient will say, I know the data is better for bypass surgery, but I don't want to go through that bypass surgery, which has the initial risk for surgery. I don't care about the long term. My uncle died during the surgery. I don't want to go through surgery. So this becomes a very multivariable question. But in general, multi-vessel disease in diabetics, left main or proximal left anterior descending, I would prefer CABG. If not, then PTCA. And again, technology-wise, we are very advanced nowadays. It is not the question of if we can do it or not. The question is, should we do it or not? So PTCA can be done almost everywhere except for few bad cases. But the question is, should we do it or not?
Very interesting. Do you suggest no angioplasty for asymptomatic patient, even if there is an occlusion is 90%? Very good question.
Very good question. I would say depending on the location. Depending on the location, and if it's a proximal LAD, left anterior descending, if it's a left main, there is no question about it. But let's say it's a circumflex and there is 90%. It is a very, very it becomes very controversial to fix. So there are other tools you can involve. You can use a nuclear stress test, whether it's showing ischemia in that territory. So that why? Because once you show ischemia in that territory, there are other research papers which has been done on those subset of patients. Then you can justify angioplasty. If not, then there are some other cath lab tools you can use like IFR and this advanced tools. Then you can do this angioplasty. However, if the patient is completely, truly asymptomatic, like there are many patients with STEMI here, they will be asymptomatic, especially in Bihar. Their kid is saying, okay, they're having difficulty, but the father is like, no, I don't have pain because people from here are like very hardy. That's my experience. So truly asymptomatic, then it's a controversial question.
So thank you all. I think we are coming to the end of our discussion. There are no questions now. What I will say is thank you all very much. Great things, great education going on in the clinical cardiology and things like that. I'm very thankful to all of you, and we are waiting for the next session. We will let you know what is the topic next on next Friday. So thank you all. Thank you, Suven. And thank you, API. All the API stalwarts and Dr. Tiwari, Professor Tiwari, for his very apt vision for this project. Thank you all. Good night.